So, welcome to the second session of today. We will have two talks. The first talk is from Eleonora D'Arnese, who graduated here in Polimi, and now she is currently lecturer in biomedical AI at the School of Informatics in the University of Edimburgh. So please, Eleonora.
Thank you. So today I will present you this talk that is deep learning for microscale imaging, challenges and advances in osteoporosis analysis. As Giacomo kindly introduced me, I have studied here in Politecnico di Milano from biomedical engineering to computer science for my PhD. And after a year and a half of postdoc, I have started in October in the University of Edinburgh as an assistant professor. And my main focus is like computer vision applied to medical image analysis. So today we will talk about osteoporosis, and what we want to find out is, can we understand better the pathway from the beginning of the pathology till its later stages? So what we know is that going from a higher life expectancy, we have an older population, and so we can see an increasing in occurrence of fragility fractures and chronic diseases. The other part is that we have osteoporosis that increase the fragility of the bone, and medical image can help us in analyzing the fracture and its nature. The problem here is that generally when we have a fracture, we can find it at the macro scale. So if you have ever broken something, you will go to the ER, they take X-rays, and they can find and detect the fracture. But then it's kind of too late. It's already occurred, and we just have to put a cast on or do a surgery if it's like a not so nice fracture. But what we want to do is, can we understand where and why the fractures has occurred if it's not like an incident, and so in that sense we cannot really prevent it. So at the macro and mesoscale, we know that the fracture is a disease that is identifiable when it's occurred. But at the micro scale, what we can understand that is, if we know and we learn to understand how the structure of the bone is and how it changes, we can really start to predict the fracture before they occurs. We have some problem here, because at the macro scale, we know that we have X-rays and CT images, quite nice. We have differences in healthy and osteoporotic patients. So we can look at the image and have a nice understanding, for example, with different features that are distinguishable not only by naked eyes, but also with deep learning techniques, where the osteoporotic bone is more spongy, has larger holes, and a more dense presence of holes in that. The problem is that if we want to understand how the bone changes, we need to go at the micro scale. And here we are interested in the morphology of lacunae. Lacunae are small holes inside our bone where cells live. And the cells that live within these lacunae are the one that takes care of reshaping, reforming, and distracting part of our bones. Here we have synchrotron radiation micro-CT. So it's a technique as a CT scan, but gives us super small samples and the information at the micro scale. But there we have some huge problem, in the sense that we have low interclass and super high intraclass variability. What does this mean is that if we look at the two samples, that one is healthy and the other is osteoporotic, we cannot really see that much differences in them. It's just sort of grayish with small hole. And what we know is that inside the same sample, we can have a lot of variability. So it's quite hard for deep learning to really perform well. So how we have proceeded? So this work was done in collaboration with the mechanical engineering department, and they had acquired 3 samples per patient from hip replacement surgery. So we are not really taking bone from a living person. It's after the surgery, we take 3 samples per person, and we have this sample taken to the synchrotron and put under pressure. So we have 3 different loading steps, and these generate our data set. So here, a bit of a problem in the sense that each volume is like more than 3K by 3K per image, and we have more than 2,000 images per volume. This means that we have quite a lot of data, yes, but not that easy to analyze, and we can reach a resolution of 1.6 micrometer per pixel. So we are super deep into the resolution part. What this produces is images that can fall into 2 different groups. One is between -1 and 0, and the other is between 0 and 1. This is done pretty much for acquisition protocols. And so what we have developed is 2 different approaches to treat them. If we look at this image, you can hardly see the bone, that is that super dark gray part. And so what we have done is normalizing the image and clip the intensities to get a better view of the data. We have then segmented our bone by applying a Otsu method for segmentation and a K-mean approach depending on the 2 different groups of images. And thanks to morphological operation, we have refined and extracted only the region of interest. At this point, by masking, we have extracted the information that we care about, and in the end, we have extracted patches. This is because, as you can imagine, working with images at that resolution and that dimension, it's not straightforward. And since we were interested in small objects inside the images, going with patch-wise application was more convenient. So what was the first part? So as I said, we are interested in lacunae, and so why not start to segment them? It's something that we really care about, and we have asked, okay, we need to have some ground truth, but imagine how happy were the mechanical engineer when we asked to segment more than 30K lacunae per image. So since that was quite a lot of work and not super nice to be done, we got 8 images as ground truth. It seems like, oh, only 8 images. Yes, but they are quite a lot of information in there. So we were able to extract around 584 patches, and we used these to train a unit model. And so what we get here is that by using a mix of dice score and focal loss, since we want to focus on something that is unbalanced. So the lacunae, although we are working with patches, are still underrepresented if we look at the entire information of the patch. We were able to get a first network that was good enough to create pseudo-labels. So what we have done is approach this problem as a semi-supervised method, in the sense that we combined another 8 images generated by our first model to train a second one. Not that much changes, in the sense that we go to high score, focal loss again. And now, at this point, we were okay with the results that we have gotten, in the sense that they were accurate enough for us to detect the object of interest. So we were not super into being as accurate as possible in segment the lacunae, but more interested in we can find all of them and get a rough shape of them. The idea then was, okay, we now have the lacunae, we want to classify. So what we want to classify is healthy versus osteoporotic patients. So the idea is that, okay, if we have this information, a model should be able to automatically divide what is healthy from what is osteoporotic. In the first instance, we said, okay, we can just try with the whole image. Guess what? It doesn't work, in the sense that the network just learned the orientation of the bone and not really if it was healthy or osteoporotic. And so we went with a patch-based approach, and we also combined the segmentation, in the sense that if we have just our network trying to classify the patches, it wasn't working that well. But based on the knowledge that we get from the mechanical department that told us, look, lacunae are one of the objects in the bones that really can correlate to the status, so healthy or osteoporotic, we integrate in our classification network an attention module. So it's kind of taking the segmentation mask and use it and combine it with the feature maps extracted from the classification network in order to have the network look at the object of interest. At this point, by combining this, we are forcing the model to kind of look at the lacunae to make an informed decision. What we have done, so it's combining, as I was saying, the attention module, and by using a mix of mean square error and cross entropy loss, we have trained our model. On the result side, as I was saying, since it's quite hard to get this type of images, we only had 6 patients, and we have 440 images per patient, and we divide them in training and the test set. And what we have seen is that, again, if I have to look at this image, I cannot really tell you if healthy or osteoporotic if we remove like the label on top of that. But the segmentation network, as I was saying, it's quite accurate in the sense that you can see the lacunae segmented manually in white, and in green, the border that is the network segment. The green is the manual segmentation, the white is what our network has produced, and it's good enough, as we were saying. So with a DICE score that was around 63%. But what was more important is that our attention module seems to really focus the network towards the lacunae, in the sense that if we look at the GradCam, ours are covering well all the lacunae, while the one from the VGG network are not that accurate. But still, we had some problem, in the sense that we were not yet as able to really differentiate what was healthy from what was osteoporotic. And so we got like results in accuracy that are around 62 and 89, that are not that bad, but not yet something that is okay for distinguish a pathology. So the idea was to ask for information, first of all, to physician. Like we ask through the mechanical department, okay, but if I give this image to a physician, can she or him tells me it's healthy or osteoporotic? And they told us, no way, they use X-rays or DEXA. So what we get is a class to this image that is not given at this level. So how can we suppose that our network can learn something that not even an expert can really know? So the idea that we come up with was that probably that label given at the macro scale was not representative of the information inside the image. So let's think about an osteoporotic person. If all the bone is osteoporotic, that person won't be able even to walk. So how it is possible that the entire sample is osteoporotic? The idea here is that osteoporosis, it's kind of not a binary pathology, so it's not present or not, it's some continuous scale that goes from healthy to osteopenic and then osteoporosis. And so we suppose that also the image was correlated to that, and so one class was not enough to really tell us if all the sample was osteoporotic or not. So what we have said is, how can we extract more information from that single label? This was done by training a convolutional autoencoder first. It was not for reconstruction. Our goal was not to be able to reconstruct images, but to get a good encoder. So we have trained a ResNet 18 to, in a reconstruction task using mean square error to get a very good encoder. And what we have done is then taking the feature vector in the latent space and just so the last linear vector in there, we extracted it and we perform k-means clustering on them. So we were a bit of agnostic with respect to the information that was provided by the physician. We have just said, okay, the network is good enough to embed something that is relevant to the images. Now let's see if we can divide in a nice manner what was healthy from what was osteoporotic and osteopenic. So at this stage, we have no information of the labels, it's just clustering. What we have then done is taking as gold standard only the patches that were coherent from the k-means and the label given by the physician. So if a patch was osteoporotic for the physician and in a cluster that has the majority of osteoporotic samples in it, we take that patch as ground truth. So based on this, we then train our classification network only on that patches, and by penalizing the error produced on that patches more with respect to error generated to patch that were not coherent between the k-means and the physician. But at this point, we have a good patch classifier, but in the end, and this was done by weighting the cross entropy, in the end, what we want is being able to characterize the entire image, not just patches. So one choice could have been, okay, just use majority voting, 50% of threshold, that's it. The problem was that going in that sense was not super promising, and so what we have supposed is that it's not that you are healthy if 50% of the patches are healthy. We have tried to figure it out experimentally, some different threshold based on how much patches per image are osteoporotic to have an osteoporotic label. So just a bit of results. What we have seen is that in the reconstruction task, all the network that we have tested are quite good, but it was not like the real objective, so we do not care that much about this specific number. What we were willing to figure it out is, are we better at classifying the different stage of the pathology with our approach? And what we have seen is that if we go patch-wise, we have quite nice results in the sense that by applying our k-means and using only that as gold standard, we have seen how all the numbers are improving, and in the macro average especially, we were able to go up to 76% in classification. And the nice part is also that we are quite balanced in osteoporotic and healthy. We can see that the majority goes in osteopenia, that it's quite okay, in the sense that if you think it's like the class in the middle, so we can assume that healthy person can have some part that start to be osteopenic, and the osteoporotic people has also some osteopenia in them. We then explored the results based on a 50% threshold, and we have seen that the results drops. So if we just put a threshold for the whole slide classification at 50%, the results were not good among all the state-of-the-art approaches. And this was coherent with the previous part, where we have more data pushed towards the osteopenia, that is the in-between class. While if we were using like a threshold studied on the data, what we have seen is that not only we were able to improve again the results, we were also able to better define what was healthy from what was osteoporotic. And if we compare, for example, on a vision transformer that was quite a hype model at the time of this work, we could see that the results were still good compared to them. Okay, the last part is not only we were able to keep the results, but we have a slight improvement in the results when we move from just the patch classifier to the whole slide one. But is it enough to just look at one modality? As we were saying, medical images has this nice twofold, let's say. Nice in the sense that we can have multiple information. The other part is that we need to discover how to treat the different information. And as I was saying in the beginning, we have lacunae, yes, but we also have osteocytes, so the cell that lives within the lacunae. And so we thought, how can we use also this type of information to get a better understanding of the mechanical feature and how fracture develop. And so we have tried also to integrate histopathology imaging, since we were able, luckily, to get that data, and since histopathology is low cost compared to micro-CT and is more commonly acquired in clinical practice, we also explored this path. And for whom was interested in this topic, you can learn more with Isabella this afternoon in room B22. But to conclude this part is, I think more on my experience, we need to find a way to optimize medical image analysis in order to be efficient and reliable. And this was kind of a mix of what we have heard previously. We have this amazing solution, but we also need to be efficient in a way that it can also be deployed in real clinical practice and to be able to be integrated in the workflow that is already there. We need to integrate information. We have tons of data and we cannot think of leaving them there. But integrating data opens to quite nice challenges, but also on insight and on the evaluation of pathologies. And on my perspective, one part that is of interest, it's like understand how we can harmonize data or adapt our model to new distribution, to data shift, and all the problems that we were talking about bias and the presence of imbalanced data. So this is kind of some important like food for thoughts in order to how we should develop new solutions to be generalizable and reproducible. So I want to thank like the Presto team and Isabella because this project was funded by the Politecnico di Milano Polysocial Award and all the team from the mechanical department and all the association of patients that help us. Thank you for your attention, and if you have any question, I'm here.
Okay. We have time for a couple of questions. There's one.
Thank you. That was a very elegant way to approach the problem. Congratulations, I really appreciate it. So here it is. In augmented intelligence medicine, basically the application of this. We don't care much about how much precise is your model, but about the prognostic value and if we can build this inside clinical pathway. So I wonder, did you ever try to consider also a time series and see if you can do some kind of LSTM applied to your deep learning? So in the way you can see if your imaging, the precision of your imaging improve over time, and you can build that in a way that we can use that preventative.
So we haven't thought about like time because since the synchrotron apply stress on it, it's kind of disruptive imaging techniques. So we do not have time series also because the bone is taken after surgery. So it's kind of one time point. What is in my mind that I think can really help is understand how we can correlate this information at the micro scale with what is done at the macro scale. I mean, I do not think that in clinical practice we will ever say to a patient, oh, let me do a biopsy to take a sample of your bone to understand if you have osteoporosis or if you can develop as kind of early detection. I mean, I don't think that one in this room would be okay to this procedure. So what I think it's really interesting is twofold. One is trying to figure it out, can we correlate this information to a DEXA or an X-ray in order to augment the information that that imaging can provide? So not only being able to say, okay, there is osteoporosis when it's already there, but saying, okay, we have some sort of starting signals, we should start doing something. And on the other part, it was of interest, the micro scale for the mechanical department to understand the mechanics and the shape of a healthy bone in order to develop injectables to really treat osteoporosis and that type of fracture. So I think that that is for sure an interesting perspective, and we should go there in order to be able to help clinics. But I think that we're still missing that gap to how we can correlate this knowledge to what is done there. Thanks.
Any other question?
Thank you for the nice talk, Eleonora. I have a curiosity, not really a question because I'm not an expert of the field, but I was wondering about the fact that you usually have a few patients. And so you have, in some sense, to create items to be classified. And all, but this makes your samples in some way dependent. So you have a couple of dependencies. One that is patches belonging to the same individual. They are not overlapped, but they belong to the same individual. So in some sense, they are more dependent than patches coming from different individuals. And also you have, in some sense, a spatial dependency of the patches because they come from the same image. And these two different types of dependency may enrich, in some sense, the knowledge that you have of your situation. Is that possible to, in your opinion, for your experience, to include at least one of these two kind of dependency, so to enrich, as you did, including some other kind of information, such information into the model? Because this is something that in statistical model typically is easy to do because you model directly the errors. In these cases, of course, much more difficult because you have no models for the errors, let's say, but I guess that's something might be envisioned.
Yeah, I think that on the patch part, it should be super interesting, also in the sense that, as we were saying, the bone is heterogeneous, but in some small sub-areas, it's kind of homogeneous. So also understand the relationship and where that patch comes from can really help us in understand if there are sub-regions that are coherent, and we can say, okay, this sub-region of this osteoporotic person is actually healthy. So that should be something that we can at least explore, because it can be super interesting. The other part is that I think it's not only like the position, but I think the orientation and when they have extracted the sample of bone, because I think that if you extract it like from the hip head, probably it will react in a different way under stress with the respect to something that is taken from the femur, for example, that is more in line with the force that are applied to that. So I think that also exploring that part can really be meaningful on the mechanical side to see, for example, if the orientation is perpendicular to where the bone was taken, in that sense should be maybe more resistant because it's used to that type of pressure, while if it's taken maybe on different orientation, that can really change. So I think that it's for sure something that is interesting to explore. Thanks.
Okay. So let's thank the speaker again. We move to the second speaker of the session, which is our colleague Daniele Loiacono, who is associate professor here in Politecnico di Milano in our department, computer science and engineering and bioengineering. His major research interest concerns machine learning, evolutionary computation, games, and in particular, that's why he's here, AI applications to medicine. So today's talk is titled Deep Learning in Medical Imaging for Radiotherapy, Applications and Challenges. Please, Daniele.
Thank you very much. Just a moment. Okay. Okay, thank you very much. Good morning, everyone. Thank you for the invitation. I'm very happy to be here. And thank you, Giacomo, for the introduction. As Giacomo already mentioned, my research interests span across several application domain of AI, but the focus of the talk today will be about my recent work on AI applied specifically to radiotherapy. So first of all, I just wanted to introduce radiotherapy from a very high-level perspective. I'm a computer scientist, so this will probably benefit especially the people in the audience that doesn't have a medical or biomedical background. So just a very quick overview of radiotherapy. So radiotherapy, the general idea is to use high energy radiation to damage cancer cells. But the real key point of radiotherapy is that we want to preserve the healthy tissues around the actual cancer. And in order to do that, we need to deliver the radiation in a very accurate way to the tumor that we want to target. And this is done with a very advanced type of delivery machine. Here you see one of the type of the radiotherapy treatment, and the one I will focus more in this talk, that is called VMAT. And in VMAT, the machine that delivers the radiotherapy, the radiation, is a very advanced machine that allow you to control the shape of the beam of the radiation through a component that is called collimator, that is basically a multi-leaf structure that you see in the picture above here. And through the movement that can be controlled of the leaves of this structure, it's possible to shape the beam of the radiation, and through the rotation of the machine during the delivery of the radiation, it's possible to target a complex 3D area in the body of the patient, and so to target the tumor and not the healthy area around. So this is used in a workflow that is the workflow necessary to achieve this goal. That can be divided in 4 main steps. In the first steps of the radiotherapy workflow, it is necessary to acquire the anatomical data of the patient through a dedicated CT scanner that allow you to actually acquire the 3D anatomical data in the same position the patient will receive the radiotherapy treatment later. In addition to this type of imaging, it's possible in this step also to acquire additional modality of imaging, like for example MRI or PET, that can be very helpful if you want to identify better some type of targets. On the other hand, this possibility of having multimodality also come with several challenges, like the need of having a much more complex imaging acquiring process, more stressful for the patient, and also more difficult to combine together, because the final goal will be to have a combined imaging. And due to the fact that we really need to be very accurate in the targeting the tumor, this step can be very, very challenging. After we acquire the imaging, the next step will be actually identifying the target to treat with the radiation, and also the part of the body that we want to preserve from the radiation, that are called organ at risk, as you already heard in the talks this morning. And this is typically done by a radiation oncologist. And if the treatment is very complex, so the target is very complex, this activity can take several hours of work. So it's something that we definitely would like to improve using AI. At this point, we have the imaging, we have identified the target and the organ at risk to preserve. We can now start generating the actual planning. The actual planning means that we need to control the rotation of the machine, the movement of the multi-leaf collimator, to be sure that we can actually hit our target and spare all the other organ at risk. This is involves solving a quite complex inverse optimization problem where we need to know and try to understand how to move all these in such a way that we hit the target. This is done using dedicated software that can solve these inverse optimization problem that are called treatment planning systems, but it still requires a lot of adjustments that are typically done by medical physicists. And again, if the treatment is complex, especially when the treatment is complex, this can require a lot of expertise from the medical physicist to actually optimize the plan and get a good plan for the treatment. And finally, we have the delivery. Even in the delivery step, we are not yet done completely, because before actually delivering the radiotherapy to the patient, we need to do additional step to be really sure that the treatment is effective as intended. And in general, this is done mainly through with two activities. The first one is a quality assurance activity, where we basically try to make sure that the planned dose distribution is actually accurate with respect to the actual dose that will be delivered. And this is done by having some dry run without the patient, measuring the dose distribution and make sure that the measured dose distribution is really agrees with the planned dose. And the second activity is typically done here is what is called adaptive radiotherapy delivery. And the idea is our patient is undergoing a treatment that can last weeks. And during this time, the anatomy of the patient might change, the tumor might reduce. So every time before each delivery, we want to acquire again the anatomical data of the patient and compare our original plan with the current anatomy of the patient by, for example, adjusting slightly the plan, or in case of major changes detected, do a partial replanning of the delivery. This is typically possible through a type of imaging that is accessible during the delivery, that is cone beam CT. The main challenge here is that cone beam CT is a lower quality type of imaging with respect to original CT, has a limited field of view, and so is necessary during the delivery do a quite challenging contouring of the target and the organ at risk with this lower quality of imaging, and make sure that we are able to compare these with the original planning CT. The application I'm going to present you now are part of the project I was involved in, so I just wanted to mention something about this project. The Automi project is a project funded by the Ministero della Salute, and is a project started in 2021, going to finish next month. Was a project aimed at automating a specific treatment, quite complex, that is called total marrow lymph node irradiation, and is done with the coordination of Humanitas Research Hospital and with the partnership of Politecnico di Milano. In the slide, you can see the picture of the main components of the team that collaborated to this project and that are among the authors of the application that I'm going to present you just now. Just to explain what very quickly what total marrow and lymph node irradiation is is a conditioning regimen that is used for acute leukemia. And the idea is that we try to target bones, spleen, and lymph nodes with radiation, and is an alternative to an older type of conditioning regimens for this condition, that is total body irradiation. And compared to the total body irradiation, we have the benefit of sparing much more the organ at risk, and so we have a much lower toxicity associated to this type of treatment. But the problem is that this treatment is very complex. The target is extensive because it's overall the body of the patient, and requires a lot of work to be actually delivered. So this is why we want to use AI to assist the doctors and the physicists in deliver this treatment. So the application I'm going to present you now span across these steps that I just introduced you before. In particular, I will focus on three application we developed. For reason of time, I'm leaving out one of the other application we consider in the project. So the first one is applying deep learning in the planning step for the optimizing the field geometry of the patient. So in total marrow lymph node irradiation, we have the added complexity that being so extensive, the target, it is impossible to treat the patient with a single radiation field. So it's necessary to split the delivery with several radiation fields. And so it's necessary to define the optimal positioning of this field. This is something that is typically done by the medical physicist, but require an excessive expertise with this specific treatment. And our idea is, can AI be used to automate or to at least partially automate this process? So to investigate this, we developed, we trained a deep learning model to try to predict the optimal position of these isocenters, starting from an imaging of the patient that is nothing more than a coronal view of the anatomical data of the patient. In particular, we combine together three types of information: the CT scan information, the contouring mask of the target, and the contouring mask of the organ at risk. These three types of information has been merged together in a single imaging, and this is provided as an input to our convolutional neural network that has been trained on around 100 of previously created plan from the medical physicist for treating TMLI. And the result was the prediction from our model of the positioning of the isocenters, and so the field for the treatment. In order to evaluate the quality of the result of the prediction of our model, we ran a user study with the blind test. So the three medical physicists were presented some plan, either generated by the AI or by manually generated from the physicist, and they had to evaluate the quality of this plan. The results were very promising. None of the generated plan from AI was considered non-acceptable from the medical physicist. And also there is quite similar performance in terms of the evaluation of the physicist comparing if we compare manual plan and AI-generated plan. And considering that the manual plan were actually delivered plans, so plans that were already the result of several adjustment and editing, this is showing a very promising result for the actual use in the clinical practice of this model to assist the job of the medical physicist in this treatment. The second big area of application that I want to discuss is the synthetic CT generation. That is a type of activity that can be used in 2 steps of the radiotherapy workflow. In fact, as I briefly mentioned before, there are 2 steps where we are dealing with a different type of imaging, but we need to compare the result of this imaging with the actual CT, and in particular the planning CT that is the core imaging used in radiotherapy. In fact, in the imaging step, you typically will like to acquire an MRI, but you need to combine it with a CT. And also in the delivery step, you acquire a combined CT, and you want to again compare the imaging with the original planning CT. So for doing the generation of synthetic CT using AI from MRI or for combined CT, there are already a lot of solutions, including commercial solutions. I want to focus mainly, we studied both the problem with these, specifically for the TMLI, but I want to focus more on the application from the combined CT, because in the case of TMLI, we had to deal with the quite specific problem that we have in TMLI, that is basically that we don't have a single combined CT that covers the entire area of we are treating, but due to the extensive area to treat, we have multiple combined CT with missing area that is not covered between one combined CT and the next one. And we would like to see if AI can generate a complete CT out of this data. This is a quite complex problem, so we started working towards this problem with a slightly simpler problem. So what we did is we focused on the simpler problem of just trying to complete a single combined CT with a missing area, and also transform this combined CT in a synthetic CT. This has been done on using this network that you see here. This is are 2 generative adversarial networks combined together. The first one, the one on top, is the completion network. That is a generative adversarial network that tried to complete a combined CT with a missing area. So it was trained by using complete combined CT where we artificially removed a small area. And the architecture, as I said, is a generative adversarial network with a generator and 2 discriminators. In this case, we used one discriminator that is in charge of trying to distinguish real combined CT from completed combined CT from our AI, but looking at the entire image. And there is another discriminator that is called a local discriminator that instead focus only on the completed part. At the same time, during training, we also train another network that is the translation network, that is a more classical image-to-image translation network, where we receive the completed convinced and transform it in a synthetic CT. Here you see some results we obtained on this data. As you see, the network is able to do a quite reasonable completion. On the left part, you see some example of a convinced CT with a gap filled by our network and compared to the original data, and also to do the transformation in a pseudo CT, in a synthetic CT. The results are still not good enough to actually having a clinical use of this. If you see the absolute error is, the percentage absolute error is above 2%. In order to have a safe clinical use, we want to achieve a performance that is just below 2%. But the promising part of this is that the amount of error introduced by the completion is not as extensive, and so we are working with more advanced model to try to improve even more this result and make this clinically usable. And the last application that I want to present you is probably the most obvious and popular type of application of AI in radiotherapy, that is the target and organ at risk segmentation. This application again is very popular, so there are already a lot of open source and commercial models that can effectively do an automated segmentation of organ at risk and of the most popular targets. On the other hand, if you have a very specific target, like for example, in the case of TMLI, you need to, of course, to still train your own model on your private data. So this is what we did in our project, but I don't want to focus this part on the model, on the segmentation model we developed. The model is currently under clinical validation, has been used already in Humanitas Hospital to treat more than 10 patients. We are getting promising result. The prediction of the model are really helping to save hours of work and also generally required minor edits. But what I want to just quickly present in the last couple of minutes here is what are some activity we are doing on the analysis of this model when in terms of how to integrate them in the clinical practice. And in particular, we tried to study some property of this model that might be critical when we actually use them in the clinical setting. The first one is the fairness. While analyzing the quality and the performance of the model, we discovered some unexpected result in terms of performance of the model on the male population compared to the female population. In fact, you see here in the slide that the major performance metric, that is the DICE score that tell you how good the segmentation is much better on the male population with respect to the female population. This was kind of unexpected and difficult to explain also for the clinicians, given also that the data set is pretty much balanced between male and female in terms of number. So we try to guess that this might depend on some specificity due to the anatomical structures, and we try to train an additional model with anatomical information, additional anatomical information as an input, and we try to see if we can mitigate the problem. The result of the mitigation was pretty poor, but the analysis of what's happening in different regions of the body allow us to see actually that we do see some benefit of adding additional anatomical information in some specific region, especially, for example, in the abdominal region. And this is leading to the idea that we probably need to target additional structure that are not currently in our additional input that might solve this fairness problem. And also this might be a model to study from the explainability point of view. Well, this is just to, as a side note, the adding anatomical information as an additional input allow to generate segmentation that are more accurate in some specific region. And finally, and this will be basically the last thing, we are starting also working, this is a very ongoing project, so this is just a very preliminary result. We are starting working on the uncertainty estimation of the segmentation model we developed. This is also very critical when adopting this type of models in the clinical setting, because this can help raising the attention of the radiation oncologist on the area where the model might be less confident, and so can also help the micro refinement of the segmentation of the model. Okay, this is basically what I wanted to present to you. The result, the application I presented you were specific for TMLI, were developed specifically for TMLI, but are very general application in radiotherapy. And connecting to what has been said in the previous two talks, the ongoing direction we are trying to explore more is the explanation of the prediction of the model we developed, the analysis of the uncertainty, so the confidence of the model, and the bias and the fairness, because these are critical area the more this model become ready to use in a clinical setting. That's it from me.
Okay. There is time for a quick question. There's a question there.
Hi, thank you for the very interesting talk. I was wondering, for the first application that you talked about, so the optimization of the isocenters position, I couldn't help but notice that the validation of the model was based on evaluation by a physician on the position proposed by the AI. I was wondering if it's possible at all, or if you have in mind to also validate the model based on the outcome of the procedure, comparing the procedure done when the isocenter is done by the AI or by a physician. For example, by comparing, I don't know, the amount of healthy tissue that is hit when the position is chosen by AI versus a physician. And also, second part of the question, if animal models or any kind of preclinical model is possible to test, to do this kind of procedures, because I see that this is like the standard for a normal drug discovery pipeline. But here you mentioned that this procedure is already tested in the clinic without any preclinical study, yeah, for example, with an animal model. Thank you.
So thank you for the question. So for the first part, it's not really, it's kind of tricky in the sense that once the AI is predicting the position of the field, there is an additional ongoing optimization process that try to still meet the requirements you have in the treatment about being sure that you deliver the prescribed dose to the target and that you reduce as much as possible the amount of dose to the organ at risk. Is it possible in principle to compare the optimality of the final dose distribution, starting with a manual positioning of the isocenter and the final and the predicted positioning of the isocenter from AI, but is not really. It's more about getting a valid plan, so a plan that meets some constraint, and so it's not exactly something that you can measure and compare so easily. Okay, I don't know if I'm able to, was able to explain the point. So it's possible, and the other difficulty is that is quite difficult for us to have a complete pipeline, because this process is done with commercial clinical software. So the number of plan you can evaluate in this process is quite limited and require a lot of time validation. But for sure is an interesting problem, and definitely is something that need to be considered. For what concerns the preclinical validation, currently most of the techniques we are developing are more in the perspective of assisting tool that either radiation oncologist or the medical physicist can use as an initial starting point for a real treatment. There is no output from the model we are developing that is directly used in the clinical setting, but there are these are like some initial solution provided to the doctor or to the physicist that then requires still final adjustment, final editing to actually generate the final planning solution for the patient. So this is how this is currently used in practice. This is the idea. The clinical validation I meant was mainly actually assessing more accurately the amount of changes that currently has been done on the predicted segmentation of the model by the physician before actually delivering the treatment. The typical setting you are referred to that is possible to do, is something we plan to do in the future, is an interesting idea is to compare, for example, the type of solution the physician will propose as a final planning for the treatment, starting from scratch compared to starting from an AI. This is something that is typically done in radiotherapy, and is important to study if using an AI can bias the decision process of a physician, especially of a less experienced physician that might rely more on the AI solution instead of what should be done. But in this sense, also the uncertainty estimation might help raising the attention in specific area of the plan. So.
Okay, let's thank the speaker again.